So I'm going to start off with one or two slides. These are just brief intro slides, and then I'm going to concentrate on stuff that people have submitted to Stu, and we'll just make sure that we're covering the things that you want us to cover. So 1,500 different people a month now use e-Healthscope. We have a patient record in there used by Call for Care and care coordinators, and that's 10,000 different patients a month are accessed, their records are accessed. So the scale is just way greater than it used to be, of course. All of you, I hope, will know that log on has been automatic via the fact that you're logged onto your PC at the beginning of the day. So we know who you are because of that, and your permissions still are those that are given to you by practices, although one of the things we'll perhaps have a brief look at is the new permission system. And people outside our area, that's people like NUH, county and city council, and healthcare trust, can also get in using a thing called Azure, which is just like Windows login, only it's Windows login in their own organizations. So they, as long as they use their password and username as they would when logging onto their PCs, then we can recognize those people too. So we can see that the users are spread quite widely. So this is just a view of the GP practice users rather than anyone else. What you might say is that the two lines at the bottom are mid-knots lines. I don't think, oh, yes, you can see the key. And perhaps usage there isn't quite the same. Nottingham West is the smallest, and fights well there, but you'd expect that, I guess, given its provenance. And City, of course, the largest CCG there at the top. Remember, we get data in every day. So at night time, we have a huge engineering process that takes all that day's read codes from system one. We get the whole of the data set of read codes from EMIS Web every night. We get admissions and discharges from our 3 acute trusts, includes Bassett Law now. We get community data telling us which services patients are receiving from CHP, City Care and PICS. We know which services all our mental health patients are getting from Healthcare Trust. And we get the services that social care are prescribing on every patient now above the age of 18 since COVID. Used to be 65 plus from both city and county councils. And then we've got flows every week or two from NEMS and more irregularly from a variety of other sources. So that's what makes us different. What do we collect that data for? It remains direct patient care. And you'll all know that the CCG, for example, have limited access to the data in there because it is intended for health and social care professionals. The Caldicott 2 guidelines define clinical audit as being part of direct patient care. So that's clearly a key part of the work that we consider e-Healthscopes for, why we collect that data. We have profiles for healthcare planning, which is the key secondary use, as we call it, direct care of patients, primary use, secondary use, anything else, but care planning is such an integral part of what we need to do. And expressly, everybody knows that it's not for performance monitoring unless there's some kind of prior agreement, as for example, with a scheme like ESDS. So I should say that the reason we have been successful, unlike anywhere else in the country, is because of these rules and because of the focus on healthcare planning, and of course because we solve the engineering problem, which other people haven't done, of coping with that amount of data every night. So here's a list of the things that you guys have submitted. And I'm not going to go over this list now. We're going to attack it bit by bit. It's going to be the core of stuff that we do for the rest of the day. These are three things that I'm going to be talking about. Briefly about the new permission structure, at least at some point, but I'll do that later on to make sure that we have time. The new user interface, I'm going to mention bits and pieces, what's going to be going on long into the future, and what essentially will become sort of second-class stuff, and the profiling tool particularly, because it's going to be central, taking over from things like the dashboards. And so the core of e-Healthscope moving forward is going to be some of the things that you're well used to and some of the things that you probably aren't. So documents and services, largely unchanged, very heavily used. All the stuff in F12, for example, that links to documents, all that served up by e-Healthscope, and it allows us to do a million different things, such as checking that every link still works, which we can do automatically. Indexing on the content of every document, even if it's not one of our own. If it's held on a distant site, we drag it in, index on every word, and then get rid of it and just link to that document, and so on. So there's a whole number of advanced things. We can also track the number of times each document's used, and we know we can do that by CCG. We can even do it if we want by individual, though we don't deliberately. But if any individual ever wanted to know about usage, well, we could supply that data. And then workflow, of course, and KPIs, the community-wide KPIs, which I'm sure you all know about, key to things like ESDS, previously GPEDs. And the reason why we are different, because we provide that proactive care. The profiling tool, as I mentioned, the logs that many of you will know about, and the patient record, which comes in two guises, one of which works on a smartphone and is really aimed at people like NUH, people wandering around wards. Although, interestingly, we can't get them to see that that would be better than sitting down at a laptop. And dare I say it, there are probably political motives behind that. I want to just finish off with this, saying that we have a stream of senior people from around the country coming to have a look. We had a formal assessment because CCG board and ICS board wanted to make sure that the ICS ambition was beyond any kind of local idea what that ambition should be. They got Gartner in, who are a global company. Gartner concluded by saying there's nothing like this in the UK, largely because of the NHS number. It probably puts us ahead in the world. And we forget that that NHS number ties up so much information around the system, which is really hard to do, interestingly, in places like the US. However, having done all this for a number of years, we know what the main problems are, and they're not really technical. The fundamental problem is that general practice is primarily expected to focus on whoever is coming through the door on the day. And we get torn off a strip if we don't deal with that person. Whereas the fact that we've got people languishing on a combination of beta blockers and calcium antagonist is okay, that's acceptable, if you see what I mean, even though it's clearly dangerous to patient care. So we do need that fundamental change. All of us know that in COVID time, when patients initially weren't contacting us, that suddenly they could cope with their coughs and colds and so on. How on earth can we make that common practice so that time is freed up to be able to do the job that we really want to do? So from now on, just before I go into that, I'm going to have one of these pauses. Now I can't see the questions at the moment, but this is the list, and we're going to move on to the logs and issues log. Did I say it first? So the two that people wanted to look at were the meeting log and the issues log. So I have chosen the meeting log first. Now the permissions I've got will allow me to look at meetings, but not to look at actions. There are three things that we essentially put on the meetings log, and for those that don't remember, meetings logs found under the logs menu. and clearly it's called meeting stock. You can show meetings, you can show the actions from meetings, and you can tie everything together through a strategy if you want to. That's a bit upmarket, I suspect, hardly used. The crucial thing is that you can have many different kinds of meetings. We put our partners meetings in, for example. Not sure how many do. I definitely don't go hunting around the scene for that kind of stuff. And in fact, our system engineers can't see that kind of stuff. It's one of the few places where they're not allowed to go. Likewise, they can't see the actions, let's say, that come out of clinical meetings or any kind of meeting. The point about these is that you can choose whatever type of meeting you want to look at, and here's the bunch of clinical meetings within the date profile we've got set. And we can look at partners meetings, for example, and so on. You can, if you clicked on actions, and unfortunately we're not going to see them because I've got these engineering permissions, and that's because I then see pseudonymized data. I can't show you real data, of course. Crucially, you can see those actions from one meeting, or you can see them from all of your meetings. And then when you're looking at them, you can look at proposed actions, or those that, this is the most useful, in progress and proposed, so not the ones that are completed, in other words. We'll use that at the beginning, say the partners meeting we done. And because it's a partners meeting, some of the time we will elect to cover all actions to make sure that we've closed off the stuff that's hanging around. To add a meeting, it's just like everywhere in e-Healthscope. You simply click on that plus and you select your practice code, you select a date. Remember, those date icons allow you to select a date in a very simple way. You decide what type of meeting it's going to be. You can note down the people present if you want. If you're ratifying minutes, you've got a spot to do that. You can put down any comments if you want to, and then you just save that and you have a new meeting. At that point, you could attach actions or minutes. And so I noticed before this, by the way, that although we can see all the clinical minutes written up in the documents, and they all get stored in documents, so you can access them that way if you want to. Only one of them was actually uploaded here to the clinical meeting. That's what that sign means. This is so that you can upload documents. And it's really easy to do that, either from your local place. Here you can see we've got the attached minutes. I haven't checked these before. Heaven knows how embarrassing these are going to be. If I did go to them, there you are, but not too bad this time. We won't dwell on that. I'll go back. So you can add actions, you can add meetings, and dare I say, if you write up your documents and you like to keep your meetings in the documents library, well, you can wander back to documents, and in fact, you can link documents to meetings from there. So wherever you are, can you see that little link sign in documents? So I just clicked on documents to get here. You could choose guidelines. Of course, if you're linking minutes, you would in documents choose minutes. And I'm going to get rid of referrals. Absolutely nothing to do with that as a topic, something I was doing earlier on. And so now we'll see all the different minutes of meetings. I could limit that to clinical meetings if I wanted by typing in clinical, for example. So now we've restricted it to documents of type minutes on all topics, but with the word clinical in their title. And then to link them in, I just click on that. And if that comes up, I'm allowed to link to a meeting, to a significant event, or to a practice audit. This was a huge wow for us, by the way, when CQC visited. We knocked up 6 clinical audits in the space of 12 hours. I'm not sure whether I should be proud of that or not, but the fact is some of them were lying around, some of them we found really to do through e-Healthscope, and we just created documents, linked them straight in, so that they're all present and easy to go through when CQC can visit. So having chosen meetings log, for example, I can then link it to any particular sort of meeting. So there you are, and there's a particular clinical meeting that I will be linking it to. So from the meetings log, what we did was to explore how we can add a meeting. We could see that we could list both meetings and actions, and we could filter the meetings on types of meeting or on individual meetings if we really wanted to. We could also link documents, either external documents from here by clicking the upload document, or if we wanted to link documents that we've created in e-Healthscope previously, we could just wander over to documents and link them up from there. I'm going to pause briefly. Anything that anyone wants to ask about the meetings log? I'm not visualizing anything at the moment, so I'm going to plow on for now. If you think of something later and want to add it, we can always go back. Don't worry about that. So the second log people wanted to know about was the issues log. So in this case, what we have is a log in which people record issues they've had with other providers. Again, it's under logs, and there was meetings log. In this case, it's issues log. And when you get there, you have the usual. Sorry, let me just make this larger. I realized it wasn't full screen. You have the usual display with a bunch of filters above, as we saw with meetings, where you can narrow the number of things that you're looking at. And then in this case, a bunch of issues that have been reported. And you can see this was reported on the 16th of September, 14th, 13th, and so on. Regularly used. We do sum these up by themes. So if you ever wanted to look at all those around unnecessary admissions or discharges with the wrong medication or whatever, you could filter and just see those. All the replies, and these very early ones, of course, are much less likely to have a reply, but as you go down, you can have often 4 or 5 different linked conversations that go on once a person has submitted something. But let me say that the CCG has got its act together over the last, I would say, definitely 2 or 3 years. This used to be a bit hit and miss in terms of the time that it took to react. Nowadays, they've been really, really good. And it's partly because a lot of this is aimed, I must say, at NUH, and NUH have a first-class person on the other end who takes all these, looks at them as being positive opportunities to change things round, and invariably goes to the relevant person and asks them what happened. And I think it's fair to say that the majority of these get resolved amicably. Very often, it's clear that there was a significant problem. There are some where you look at it and you think, as a GP, I'm not sure I would have reported that, and you know, the reply that comes back usually supports that. But a lot of them are talking about stuff, workload that, for example, is being expected in general practice and unsafely so. So, you know, can you follow up the result of this test that I did? That sort of thing, which is obviously unsafe because we don't have access on many occasions to those results, and certainly not easily. How do you add issues? Well, you just go to the issues log and you click on the little green plus, as ever. Usual thing, to add something, green plus, to edit something, the edit pencil, to delete something, the deletion sign, and to complete the form, you just make a bunch of selections. So this will be the practice code from where you're reporting. If you want to record an NHS number, you can. That obviously isn't publicly displayed, but it's a very useful way of having a tab on the case that otherwise can get lost. And if you don't have specifics, usually we find that the follow-up is unsuccessful. So if it's about a patient, do record it. The organisation that you're at and the provider that you've felt there's a problem with the care of. You can put a date in as before. You can talk about the type of issue, so we can categorize it and serve it up for other people to see in groups, some sort of title and the description itself. And as we say here, don't include any names or NHS numbers in this lot, because this comment is made public so everyone can share in the issue that's gone wrong. One thing just to be aware of is that when this log was created, perhaps remarkably, it was created before the report for mid-staffs came out. So we are talking about a little while ago now. When we first introduced it, one of these CCGs, in fact a very large CCG, came back and said, you've got to take that down because we don't have the staff to deal with this kind of thing. With that particular CCG, dare I say it, not for the first time, I said, no, I'm not going to do that. You're going to have to find someone or you'll be legally responsible. And sure enough, they found someone. And then the mid-staffs report came out and everybody's ideas changed as to what one should do about care. We knew about it in general practice, that unsafe stuff was going on and that no one was able to report it because it was just no mechanism. And sometimes you just have to force the hand of people to do the right thing. So if you want to follow up conversations on things, let's wander down. If I go to the bottom of this list, I'm going to go a bit deeper into it. Let's go to the 5th page, for example. Where does this take us to? We're going back to July. Can you see now we've got discussions with replies after them? So there's one with 3 replies. If I click on that, I'll then go to the user forum, where all the replies are stored. And at any time, you can see this via the user forum if you want to. And you will see, in this case, Charlotte raising it, and then here's the issue coming back, and GP replying. Looks so that was closed successfully in the end. Okay, incidentally, if you see these things, that's because you have an option nowadays to link into the topic, so that on any page, e-Healthscope will detect whether or not there are documents and services and KPIs and workflow that link to that topic, so you can jump straight to workflow or whatever. In this case, there is no workflow, but there are services S and documents too. I'll just say that in passing. But it's one reason why linking an intranet to all the other facilities we have means that you can move between that patient area and the kind of audit capability and your intranet quite smoothly without there being big walls between that kind of stuff. So I think that's all I really want to say about the issues log. I'll pause there again. Are there any questions or?
Hi Mike, it's Stu. So there's a question in the chat, which is from Kelly, saying, is there a log for prescribing issues? And she seems to recollect there was a separate log.
A separate log for prescribing issues. I can't think what that would be. So we have an audit log and we have a significant event log, which significant event log, by the way, now called learning events. I can't think that we ever had a prescribing issue.
I think, Mike, it was something our clinical pharmacists told us about, saying if you've got any inappropriate requests from the hospital for prescribing red traffic light drugs, to put it on this separate prescribing issues log, but I've never been able to come across it.
Well, that's 2 of us. I can't. I do remember a conversation about 3 years ago about this. Did we ever? So let me just go back to the issues log. I don't like loads and loads of different kinds of log. Let me just say, So I know what my answer would have been, which would have been to try and put that in. So there is a pharmacy. That's about pharmacies, of course. Well, I can't think where it would be if it wasn't in here. And I would always have asked it to be, and if it was about a provider with a pharmacy issue, we'd have probably said, stick it in there under whichever provider. Let's choose Sherwood Forest, for example. And we would presumably have slipped in something around pharmacy to make it easy for those people. I will talk to Naina and try and come back to you.
Okay, thanks, Mike.
Because one of them will know. Any other difficult questions for my awkward audience?
Mike, Craig here.
Hi.
It's probably very, very low level. My account clearly has been set up, as you said earlier, just by logging in, it recognises who you are, but the relevant permissions clearly haven't been assigned. So who is the best person to chat that through? Because I'm certainly very much interested in starting a practice issues log, you know, and all the other things that you've spoken about. So yeah.
So Craig, you're a
practice manager.
Manager. So
yeah.
You should be an administrator.
Yeah. So when I go, for example, when you were demonstrating it for workflow, for example, I can't select. So I'm in workflow now, just waiting for it to spool up. Like practice, for example, it just says all. I can't actually use the drop-down menu for anything.
Okay. So click on permissions log. I'll do this in front of everybody while you're doing it. So I'm now going to click on permissions log. And tell me whether you can see anything on that screen.
Yeah, so all I can see is the practice codes down the left-hand side.
Practice codes down the left-hand side. Is that saying find practice administrators?
Yeah, find practice administrators. Please select your practice from the list below. And I've just actually while you were answering that previous question, I was just in this, and I'm not on the I'm not actually on the practice.
So no. What we need to do is to set you up with permissions. Do you know what's your username?
What, my email address? You mean?
Your username. Your ENOT's username.
So, good question.
What do you log on with at the beginning of the day?
BURD.
BURD.
Yeah.
Anything else?
CRA.
CRA.
Yep.
Okay. So there you are. And your practice?
Is Welbeck Surgery.
Whoa. I will give you, right, you might want to upgrade those to partner. What's your C number?
C84664.
Other people would get a drop-down list, but we would have to always assign a practice administrator. Welbeck is in, remind me.
It was was it Norcom? So I've only been here for 2 weeks, so I think we were part of Norcom.
It's Nottingham City.
Nottingham City. There you go. Thank you, Kelly.
Yeah, but you have to be Norcom for now. Unless you're City Central, do you mean? But anyway, I'll make sure you're City here.
That's it there. Nice. Yeah, that's it.
Community South. That's easy. That's it. And I'll trust you. Who you are.
Very wise.
So that you can add other people. And we'll put out a contract on you if you're the wrong person. Right. So from now on, if you click on workflow, you should get. You should go see stuff. Right.
Thank you.
With that in mind, I'm now. Unfortunately, Zoom's getting in my way here. Let me just show you something so this doesn't scare the hell out of you. Shortly, the permissions log is going to be replaced by this thing. It's called people's permissions at the moment. And it's under test, but we're using permission set up by it. And if all goes well, have I got the wrong? No. It's under wraps so that no one else can get to there at the moment. Whoops. So now what we'll see is that the ability to assign permissions has been changed so that it's not just practice managers and practice staff who can supply those permissions. And that's because we're spreading into healthcare trust, to NUH, to Sherwood Forest. So there'll be a limited number of roles that these people can have for looking at their own patients. And there's a consultant role, by the way, which allows people to see any patient so that they can deal with them in ED, but they get a question each time they see the patient notes, that particular patient's record, so that they have to say, yes, they have a direct care relationship with that patient. The trouble is we don't know who these people are, so we can't assign those permissions, which is why we're slowly changing that structure. So you can pick out patients with whatever, you can stick to a particular role, we could see all of them, and we could go for, I'm going to go for my own practice, for example. You would not necessarily be able to see all of this. You'll almost certainly find that you're restricted to what you can see when that comes up. And then you get a list of permissions that fit what you've come up with. And so here's a bunch of different people, and you can see that these people have all got permissions on our practice section across, and you can see they read, write, or teaching. In some cases, a good few people who've got teaching permissions. For our practice, that's rare to have so many people with those permissions, but it's because of the nature of our practice. And you've got some people there with a P for partner permissions. To edit those permissions, you click on the pencil as usual, and you can then add, and the point is you select them here to different types of organizations. So it's general practices that you would add to those practices. And then, because again, I've got widespread capability, you would only be able to see 84042 come up for your local practice on that list, until we could add people with different roles, add new people, and so on. It keeps an audit of all of that stuff, and crucially, you will be able to see all the people who've got permission to see data on your patients, which is a really key thing. But the number of different types of permission goes beyond the old read and write roles, which is combined, by the way, because reads so are rarely used. Partner, and you can, so those are old ones, whereas here you can see respiratory clinician, learning disability coordinator. And by having these rather refined permissions, it means that we can get a person such as the LD coordinators, I'm sure you're all aware of, who've got specific tasks. We can give them quite detailed knowledge about, say, patients on the LD register, but not let them give them the ability to see data on all those other patients we have. So in some cases, they're very restricted. In other cases, like if you have the consultant permission, it's a bit technical what's showing up here, but essentially it allows you to see any record, but you get asked that question before you're allowed to see it. And of course, that's recorded in an audit trail. So if anyone looks after David Beckham, for example, remembering back to the famous case, not at Beckham, Dorset, of a famous individual admitted to Leeds who had 2,000 people look at their clinical record. Clearly, not all responsible for that care, but we can detect exactly who's been looking at what. And dare I say it, we'll forget this, but in the same way that DNA printing allows us now to look back at crimes from 20 years ago and solve them, DNA analysis. So the fact that we have these logs with relationships between people will allow us in the future to do all sorts of things. No clinical person will ever be at risk, of course, because we're just doing our job. But these are all designed to make sure that with such a rich patient record out there, that people who really don't have any kinds of role or business looking at records don't. Brill. So that's just a foretaste. It will be moved out to the permissions log, and we will replace that permissions log at some point in the relatively near future. I will produce a video so you can see how to use that. The big difference being loads more roles, and the fact that other people will be able to assign to some of them, particularly like, you know, who's the urology clinical lead for your area? Well, and few people get to know that. Brill. Anything on permissions? Any questions around? None at all. So let's go back to our list, and the next item was on dashboards. I'm going to briefly show you the traditional dashboards. They are still very highly used. I think you should be looking at using the profiling tool, which I'll show you. So dashboards, top of the list at the moment, and it's the third most commonly used thing in e-Healthscope, so it remains very highly used. More than 100 people a month will look at this. Down the bottom at the moment, the profiling tool, up to 40 people a month looking at that. Very different people. Dashboards used by practice a lot. Profiling, the analysts are now looking at profiling all the time. And that's because we've done a lot of teaching for analysts. The dashboards allow you to look at all sorts of different things. So you can concentrate on admissions, or you can look at some clinical issues, clinical topics. You can look at referrals or mental health or whatever. And particularly the clinical topics can be quite useful. Admissions is probably one of the commonest things it's used for. Each time you get the chance to select a bit of detail, you get something by default, but probably the commonest looked at dashboard is emergency primary diagnosis admissions, to try and see how you're doing. And if you click on that, for some reason we've got the on surgery selected. I don't know why, but let's not be unfair here, and I'm going to go straight to our surgery so you can see warts and all, and I won't focus on someone else. Now, crucially, when we do this analysis, we take into account the number of patients, the age distribution of those patients, and the gender or sex of those patients. What we don't take into account is deprivation. So our practice is, I think, 9th or 10th out of 12 practices for deprivation in Nottingham West. So you would expect us to be around that 9th or 10th, I can't remember which, mark. And the key, and remember you're looking here at your ranking in the CCG, so that's your 12 or the 12 Nottingham West practices. Over here, the ranking in all the practices across the CCG. And there's a score. So this is all diagnoses. If that score is high, and 100 is definitely high, and 1 is definitely low, well, one thing about 1 is that you'll quickly see that if you were to drill down, and like everything in e-Healthscope, wherever that it's in blue, or if you move over it, you usually turn to your hand, then you can drill down. If you click on that, what you'll see is a graph that will be full of noise because that score's low. In other words, it'll be just chance that makes you bottom of the pack. I can usually find a green one where we look outstanding, but of course it's just chance. So, sorry, we're looking at trend. Normally, what you'd see when you first come in is no trend. So I'm going to show the usual graph, and I'm going to go back to, that's by deprivation, and I'm going to go back to linear. So you can see, so this is a typical graph you should get shown. And these are the confidence intervals. So yes, we have the highest rate for whatever this is, diseases of blood-forming organs and immune diseases, which is, anyone who knows medicine, is going to be a rather small number. And you can see that we overlap with pretty much everyone. The only person we seem to touch with is the oak, so we might be significantly different from those. Overlapping confidence intervals, there's no statistically significant difference. And if they're not overlapping, then that difference is statistically significant. So this is largely noise. Just to play around with this, you saw some different possibilities. Deprivation, you can scale that. This was a much requested feature. And this means that no longer do you have an underground map, the London Underground, dead clear, but not representative of the true geography of London. Paris, terrifically complicated, but you can see exactly where you are in Paris. So this is the sort of Paris equivalent, where you can see the distance between practices now recorded. So Bramcote and Chilwell Valley really rather less deprived. They're getting towards Rushcliffe. No one can match Rushcliffe, of course. When it comes to richness, at this end of the spectrum, we can't match City. City IMD goes down to 50 or so, or 50 to 55, and the most deprived areas, of course. Eastward, our most deprived area, and that's frankly around 13. So yes, you can adjust that to show deprivation in a more real way, and you can trend by clicking on that button to show how things have changed over time. And now you get line graphs, so you can then pick yourself out. If you hover over the practice, you'll see how things have changed. So this is all noisy data, right? So the fact that we were outstanding in December 2019 by the looks of it, and terrible in 2020 July, it's all noise. That's the thing to remember. So that first graph is really important. However, I'm sure we could pick something that's much more likely to be useful. Let me go to, say, gastroenterology or respiratory. Those circulatory, respiratory, digestive, those are where all the emergency admissions are. So if I go to respiratory, which is often dominated by flu, chest infection, some COPD admissions, of course, and then I haven't done this before, so I have no idea where we're going to be. There we are, pretty high actually. We're second highest there, aren't we? We always have had a very high number. You can see as we go back to 2019 there. And dare I say it, what I'm going to do, I think the best way to look at trends is to click not on month, but on quarter. So we'll first reduce the amount of data that we see. And having reduced it, I'm going to click on the 5 for 5 years worth, because we're only looking at a year's worth of data. And that way we'll see the picture over some distance in time. So let me just highlight us again. Whoops, there we are. So you can see that we have always had this quite high rate of respiratory stuff, improving 2017 a bit. There have never been at the really good end of the spectrum, and periodically peaking out. Doesn't mean to say that we shouldn't look at it. We know for some reason San Diego and Stapleford have always had very high smoking rates. A large number of people who used to work at the John Player factory come from the area, and some miners have been in that area, although that much more affects, dare I say, Eastwood, who don't appear here. Eastwood have a much better ratio. There's somewhere up here. There. So this is a more deprived area with some mining capability in there. In an ideal world, we would be able to match them for COPD admissions. So it's always worth looking at that kind of stuff. You can always drill down at that point, and then you will see your caseload. So you go from a dashboard that shows a large number of indicators to looking at a single indicator, but you're looking at a group of practices, and you can change the group that you're looking at, the people you're comparing yourself with. And then you drill down further to see the individual cases. So these are the individual admissions that underlie our caseload. And this is really useful if you're doing an audit, for example, and trying to work out just who those people are and what the problem is. Now, I hope you all know that you can click on an NHS number. That is an NHS number. Dare I say, you would normally see a patient's name and date of birth and true NHS number. This is a pseudonymized version because clearly I'm in display mode. So if I click on that, I'll see that patient's record. So now we're drilling down from a list of patients to an individual patient. And that's a pattern we use throughout. And you can see this patient has got multiple problems, mental health problems that we get from Healthcare Trust, tells us the services. They are in italics, so means previously under this team, these teams, not at the moment. This one's not in italics, that means currently getting home support. That comes from social services, county social services. This it shows the patient is under the continence team and the reablement team, and previously under falls, intervention nursing. Here we can see the patient's last admission was on the 4th of May. I can click on that and see all of their different admissions. So that was COVID-19, interestingly. That was at the peak of the period, wasn't it, back in April, admission. But you can see there's the respiratory admission and a variety of other bits and pieces, including depression. You could look likewise at outpatients, A&E, that there is no faster way to get a list of that patient's outpatient attendances or ED attendances. I'll always have e-Healthscope open when I'm seeing patients. And I'll copy and paste the number from system 1 into e-Healthscope adjunct to patient's record if I want to get that kind of overview, because otherwise I have to wander through loads of letters to work out what's going on. And you get lists of things there. You can open up different problems to see key data, you know, when that patient's had annual reviews, what their daytime symptoms were, and so on over the years. I won't go into all that detail. These are the MDT meeting notes, which can be really valuable. We use this a lot in MDT meetings, and I'll show you how you can do that, and here your workflow down the bottom. So we've covered exploring the dashboards briefly, going down to the individual graphs showing deprivation, and then moving down to the lists of patients underneath those, and then down to a patient record. So a lot of stuff there. I'll close that record. Maybe if I pause briefly there, any questions around that little journey? You'll clearly have to look around yourself to get the full feel of things. I'm now going to show you the modern way of looking at data. So this was data. Yeah, go on.
Sorry, there's a question in the box.
Yeah.
We use e-Healthscope to locate patients for NHS health checks.
Can you do that? Did you say? Was that the question?
Yeah, can that be done at all? Can it?
Health checks.
Yeah.
Hold on. I never do this myself, but yes, we've got the NHS health checks. Register. So registers are lists of patients. So if you go to NHS health checks, then as ever, I will only be able to see patients in my own practice. And what we show is a bunch of different things, but we start off by showing this month's invite list. So there is a list of patients who we should invite this month. And we've got quite a complicated algorithm that goes through and picks out the people that, from all that data that we have in e-Healthscope, we work out their QS score from as best we can. And then sort people so that we chuck the people at you who either have the highest risks or below a certain threshold have key data clearly missing to be able to calculate a risk, like smoking data and so on, because those people could be at high risk, it's just that we don't know. So we do structure all of that to make sure that you're always getting the most relevant stuff. And you can go back and look at the previous month's list. There are all sorts of different lists you can look at, including all eligible patients, if you really want to beat yourself up and see the size of the problem that you have. If you've got responsibility for more than one practice, you select the practice. You can concentrate on males or females. You can look at different subcategories, those you've done, those that have declined in the past or DNA'd, never responded to you, and so on. And then there's more complex stuff if you want to report on the process, where you can look at your uptake and so on. Does that answer the question that whoever it was posed? Do talk, whoever you were.
We have a yes in the chat, Mike. So
We have a yes in the chat. People are allowed to talk, especially when I say
shy.
Yeah, it's quite something. This is Zoom. I've come across it before. Now, so we're going to leap on, and I'm going to show you that profiling tool. It is new. It's I hope not too complicated to use. There's a lot of stuff still to go on it. Always, let me just go back to the beginning. So what you will see is this thing, and it's a bunch of filters. And the idea here is that you can select from across the patch to look at your population, or our population, I should say, by diagnosis, or looking at the medication that people are taking, or clinical tests. Social history we could start with. I'll just select that, for example. So we can look at carers or care home residents, or people who are housebound, and that actually excludes care home residents, by the way, people who are homeless, and so on. So any one of these categories you can kind of start off with. And we can, should we choose something like one of these? What should we start off with? People who are housebound, why not? And then we can choose whether we want to see them by neighbourhood, same as PCN most places, except Nottingham West and Rushcliffe, and anyone from there will know why. And you can look at ICP level, for example. Perhaps we'll choose ICP level for now. You can choose if you want residential stuff. If you don't choose anything here, you can look at it just by ward or LSOA or county or whatever. Social services find that useful. Useful for us too when we look at people crossing borders. Sometimes you put an age band in, sometimes you limit to a gender, sometimes you limit by ethnicity. You can choose whether you want the patient in a care home or both. I'll put both, in a care home or not. And we're saying at the moment we're going to go for active people. We could include, let's include people who've died as well. And then at that point, you map your focus. So you've made a selection. Here it's housebound people by ICP. So now the map is drawn by ICP. I'm going to click on our ICP in case you want to drill down further. And so now I'm drilling down to South Notts only. The 6,670 patients, it says, are in South Notts. And we get these different things. So I could click on the 6,760 patients, and then I'd go straight down to looking at those patients who are in the group that we've chosen. And I look at the individual list of patients. And I can look at them by sex or gender. That will tell me the age, sex drill down of the population. So now we're taking just those people who are housebound in South Notts and seeing how they fall. And so look, they're all women, these people who are housebound. And they're all 90-year-old women. Well, that's not a big surprise, just in general practice, I guess. And we could drill down further on that population. Alternatively, we could look at the ethnicity of that group. And I've chosen South Notts, which is a dominantly white population, I should say. And this will show males and females and the totals but also for ethnicity not recorded, which is second, sadly, mixed there. And here's the average age of our Afro-Caribbeans, but there are too few of them to show, rounded down to 0. All of these figures, if they're not your data, will round down to the nearest 0, to nearest 5, I should say. And likewise, we're talking about a very small number here of people who who are Asian, and the more precise numbers are shown down here. So, and the fact that this is, you can't see anything actually, is because we got to 1,000. The scale's just not coping with the tiny number we've got there. But the actual figures show that they're in 5s and the order of 10, 15 for mixed and multiple. Okay, I'm going to get back. We can do more. Well, I don't know about exciting different things. You can certainly show them by deprivation. So again, are these housebound people in our area? Remember, this includes a lot of people in Rushcliffe, and then more than 90. So these are the most deprived. And up here, we've got the least deprived. And because this is South Notts, actually, most of these housebound people are not only elderly and female, but they're rich. And maybe that's one reason why, of course, they're in their own house and not in a care home. You can see why this is a godsend for a clinical audit. You can knock something up literally in minutes and submit it. It may not be worth anything, but that's not the point. If you want to look at the care homes data, that can be really valuable. So, oh, hold on. That's interesting. I thought we'd excluded, we clearly haven't in this case. So this is looking at that population by the number in care homes. Right, that should have been excluded. I'll need to go back because by definition, we've tried to do that. But it will show you for the 50 top care homes for, in this case, South Notts, with the numbers of patients that are in there, and you can then drill down to those patient populations. Likewise, you could look at comorbidities or the drugs that they're on. You can look at what happened to these people. And if I draw a line chart, we can see the admissions and the discharges. So these are hospital discharges, these admissions to care home. There's a big peak on the 10th of May because unfortunately this is a bunch of people because of data, particularly EMIS data, where their addresses are insufficient for us to be able to work out when it was they entered a care home. The data they give us just isn't good enough. If I get rid of that, then we'll get more prominence in secondary care discharges. And this shows the familiar pattern where we can look at almost any group. You see housebound patients in flu time. This is the 10th of January, and we're just looking at 2020 data, with a significant number of discharges from hospital. COVID hits, and of course, people that aren't admitted or discharged from hospital, and now the numbers were rising. Interestingly, they've fallen a bit for housebound people. I suspect that's because the data maybe isn't quite there, although I would expect for secondary care discharges we should have all that data. So I'm not quite sure what that means. We were able to follow deaths and all sorts of things. So on the house on this population, let me just go back and look at urgent care. And we'll see that the deaths, of course, were greater in COVID time, I would expect, in this population. Let's have a look. And I'm going to show this as a line graph. I'm going to get rid of the end of life stuff. They're the urgent admissions, and there are all deaths, and you can see that's flu time, and the deaths that then accrued around the 5th of April. And now settled hugely, and we haven't seen the rise, even though we've seen a big rise in cases. You're all aware from the papers, we haven't seen the rise in deaths at all. Deaths were always a little bit behind, up to 3 weeks, in fact, behind, although obviously the closer you get to day 0, the more deaths are missing. 3 weeks ago, it's only a handful. So really useful this for looking at any lot of any part of your population, and then looking at the diseases they have, for example, so that you can now pick out those people who are housebound with depression, and we could then go on and click on that, and we go on to see by numbers or rates. We can now begin to do the comparison bit, say, you know, is it us or the practice down the road, or is it our ICP or other ICPs that have got more of a problem? Well, when we're looking at depression in housebound people, the biggest problem looks to be in mid-knots, interestingly, in terms of size of people. And there we are in South Knots with more people than City. If we want to look at this proportionally, go back, and instead of numbers, we can look at rates. And there's a third item which we haven't released and requires more testing, but you can see that when we look at rates level, it's pretty much the same across the board, isn't it? So in other words, it all boils down to numbers. It's roughly a fifth of all patients who are housebound are recorded with depression. So that was off drilling down further. Go down. The third element, by the way, will be logistic regression. So that's something new for everyone to get used to. The power of logistic regression is that it will allow us to take into account, in the first place, automatically, age, sex, deprivation, and the number of comorbidities. And our experiments show a duplicated finding found elsewhere that the number of comorbidities of your patients is more important than their deprivation. In other words, if you're healthy but deprived, you're better off than being having a lot of comorbidities and having low deprivation. So, but we'll in fact include both of those, and logistic regression will take both of those into account. As we move on, though, we'll allow you to balance the populations out by other things, so that you'll be able to drag and drop things like, you know, if you're looking at COPD patients, you'll be able to use the MRC status. Because if your area has more people with severe COPD, MRC 4 and 5, than your neighbouring area, then frankly, you would expect there to be more admissions. So it will give us much more power than we ever had in the old age and sex, and dare I say, even in elsewhere they use age and sex and deprivation, though with a technique that's not quite so powerful as the direct standardized direct standardization that we have previously used, and will allow us to look for real differences between areas. And the more we delve, the more we find that it's not because practices are incompetent or PCNs are incompetent. It's because of the workload or the makeup of that population. And that comes up, the changes in practices comes up for lots of different reasons. It can be that a practice struggles for a couple of years, and a lot of their patients leave for a neighbouring practice. And that neighbouring practice then has a more dense population of typically 40 to 60-year-olds who require care, not from younger people who don't know that it's hard to get an appointment, for instance, in practice, and not from very old people who are dead loyal and don't seem to move. And then, of course, that cohort of patients sticks with the practice and potentially for a long time afterwards. So there are lots of different reasons why these things happen. There is a well-known bias, which is to say that if you can see a difference between populations, then you will blame the people in control of those. So when it comes to looking at general practices, when people look at a graph, their instinct is always to ascribe blame to the practice. And I tested that at CCG board level when we were asked to give a population health medicine talk, and I took something where I knew that the difference in behaviour we could show from another analysis was nothing to do with different practices, and asked around the room, and sure enough, people were saying, well, it's due to this practice being bad. So whichever way you look at it, the old style dashboards have been, I think, a problem for general practice. I think not only have they been a problem, but they haven't led to much change. So it's very hard to look at many of those graphs and say, what should I do to change things around? I hope that with the new style tools we're putting together, they'll get rid of more variation so that you can see the wood for the trees and see where there really is an area where maybe the practice isn't doing as well as it might, or the PCN isn't doing as well as it might, or even the whole of the ICP. If that's the case, well, you've got to have a look and see what systems are in place and whether anything needs changing. But crucially, combining that with workflow, and what workflow does is to say, this is what you need to do, not this is where you're doing, you have too many admissions. It's the doing that's more important, isn't it? So I'm going to halt, and then we're going to look at workflow, which is one of the key areas that the people are interested in. But any questions around profiling?
Hi, Mike. It's Stu again. There's a question in the box from Kelly. Is the profiling tool dependent on information primary care enters or secondary care or both? How up to date is the information?
So for primary care, the information is yesterday's information. Where we take into account hospital data, and that's variable, and we'll shortly be able to surface that, and I'll show you there are ways, well, I can show already. If when you're looking at something, let me go back to the South Knots, I'm going to cheat and show you something we haven't released. If I type in RTS equals test onto the top of that, we will release this, I hope, within a few days. But this, next to any concepts you're looking at, has that little help sign. If you click on that, then fingers crossed, we still need to do some more testing to make sure that the thing works. You should get a listing of exactly what kind of information is there. So now click on the subcategory, click further, and you can see this one is derived just from GP data. So, and it will tell you the full set of codes, and quite often it's quite a large set because this can be a parent. It's got a % sign, means this parent. If you were to click there, you'd see all the different codes. But either way, if you click on that 4 codes in total, it will show you the 4 different codes and what they mean. So it's easy to know what's going on. So that solves a big problem when you're looking at this data, knowing where it comes from, and from that, with a tiny bit of knowledge, you will know how up to date it is. So if it's from primary care, it's yesterday. If it's from hospital, although we collect the data every night on discharges, for example, they don't code that data immediately, and only, even by 4 weeks, only 40% of their data is coded with, say, diagnoses. So some of that stuff will be up to date, some of it won't. So by 4 weeks, 40% of their stuff will be coded. However, having said that, introducing ICD-10 in some areas particularly is really valuable. There's some areas we're not good at coding, and they are in other areas where primary care, any QOF area, for example, you can expect primary care data to be brilliant. And sometimes where it's recorded in primary care and not in secondary care, there's a problem with secondary care data. What we will be doing is beginning to put together some workflows, and I hesitate to do this because we could put 1 million together where there are differences. So for example, what about in QOF areas, we could point out where hospitals think a patient has, say, COPD or diabetes, and we don't think that's the case in primary care. Well, we could surface those people so you could check your registers were up to date. And if it's for primary care, well, that could be financially useful, couldn't it? Every patient you add, assuming you get their control right, then you'll add to the income to the practice. So there are perhaps good reasons why you might want to get involved in that. We'd have to target it. So again, you don't just completely overwhelmed with workflow. Hope that addresses your question.
Thanks, Mike. Yes.
Any other questions? So play around with it. This may be your first sight of all this. There's a huge amount there. And one of the big areas will be developing workflows and KPIs where you can see that the KPIs achieved and the workflows done in for that population of patients that you've looked at, and that can be really useful. And we're shortly going to try and find the difference between the two, so that what you'll be able to do then is to say, well, it seems as though the populations we're failing with on the workflow side, in other words, when we look at workflow versus our general population, we aren't hitting people who are, say, I don't know, Asian extraction, or who are deprived in our populations. So it'll be easier to know where we have to make more of an effort. And in some cases, we can change the way we do things. It may be we need more language stuff, stuff written in Sanskrit, for instance, in particular areas where we just got to get out to that population the message, and perhaps they don't understand that peeing blood is a dangerous thing. Okay, we'll leave that, and no more questions, Stu, presumably? No. I'm going to go to, so I'm using you as the guide because I can't see what's going off.
I think it's amazing that somebody was 113 on that.
Yes, yeah, you get the odd amazing thing, absolutely. Mind you, you also get people who weigh 250 kilos, and you do wonder sometimes, especially when the week before it was 42 kilos. In this case, age is calculated from date of birth, and just pray people got that right. So, what am I looking at? I'm looking at the summary to review. Responsibility. Why am I just looking at immunization? I've obviously come from, oh, I see. I can see it checked in the filters. This was something clearly I've been doing beforehand. So, a lot of you will know about workflow. You just click on workflow to go there. And the idea behind workflow is to make it easy to point out potentially where there are things that we need to do. Workflow is not about saying you have to do X. And every time you see something, let's go to end of life, which was one of the requests, you will see consider for discussion around end of life care, or consider why. And that's because we know that in many of these cases, for example, one of the Nottingham West practices audited all this lot and found that interestingly, the least useful of our end-of-life suggestion categories was metastatic cancer. And that's because it's a better guide. Well, metastatic cancer isn't quite as dangerous as we used to think, whereas people with late-stage 3 and 4 heart failure and late-stage COPD are in real trouble. So first thing is you can pick a topic. Second thing, and you just pick a topic clearly by clicking on admission avoidance, whatever. Admission avoidance, interesting. Look, there's one patient. Oh, I put that patient on. I have to get rid of that. And I was going to show you something. Maybe I will at the end of the day. But we've got one patient, and all of the patients who were discharged yesterday who had readmissions or were put onto the admission avoidance list have been cleared up by our care coordinators during the day. So usually by 10 o'clock, this is pretty clean, and just the patients to be discussed at our next NDT meeting, it's just one at the moment, listed. So it shows that this is really quite active. I'm going to show you a second area, prescribing. This has expanded a lot, and this we hope our PCN pharmacists and, dare I say it, our CCG pharmacists have been helping out when they can. It provides an agenda of things for them to sort, where they're potentially people who, for example, are on combination of aspirin and clopidogrel, but don't have an obvious indication for that. Well, in some cases, we're missing the indication. In some cases, it was a direct clinical decision to do it, usually by secondary care. In some cases, it's just wrong and needs changing. And so you won't see all of the different categories that are there. There are many more, but if you don't have any patients in those categories won't appear on this list. And in every case, if you want to see the list of patients, then you click on this number, and I'll show you that in a minute, and you see the list. So let's go back to end of life. I'll close up prescribing. The workflows, you can limit them a bit more by looking at schemes. So we have a discovery and a management scheme for end of life. So if you were interested in discovering the 1%, you go for discovery, and this will then take all of the workflow and simplify it. So it will just show that part, and there it is, just under the underlying topic. Sometimes it comes from multiple topics, and it will concentrate then on the diagnostic stuff that you might want to concentrate on. If you wanted to look at ESDS stuff, look for the ESDS scheme, and there it is, April 2020 to March 21. Click on that, and you would see this time for a variety of different topics, the things that are relevant to that scheme. And you can then open up the different workflows to see just those. Makes life a bit easier. If you want to look at the workload, well, you just click on the thing and we can look at those people that we have to sort. There are 18 patients who have atrial fibrillation, who've got a CHAD score of 2 or more, and who haven't received anticoagulation in the last 6 months. So I can click on that and I'll see the list of 18 patients from our practice. And then we could go working through that list. We normally see the names as ever. We could perhaps see the record in here and carry out whatever actions we need to be done. I noticed that okay, no, I won't spoil the fun of that. So that's workflow. I'm just going to jump, because I'm aware that we've got about 7 minutes left. The flip side of workflow is to be able to look at the community-wide KPIs. And community-wide KPIs tell you how you're doing. And you use it in exactly the same way, so that you can choose ESDS or you can choose end-of-life management and see how well you're doing. I just sent this round to partners prior to our next meeting because actually, okay, it's COVID time, but when you look at how we're doing compared with the average for Nottingham West practices, we're pretty good at this, registering the place of death for our patients. Brill. Pat ourselves on the back maybe. We're not doing really well, are we, for anti-serum medicines in place. We're not doing well for this one particularly, end-of-life care plan, that's 12 months. So we've got to look at that. So again, if you're looking at how effective your care is, why not look at these? I think because we're short of time, I'm going to flick to something that often relates to these. So this was the community-wide KPIs. We looked previously at the workflow. So the community-wide KPIs, if you were to look at the primary care quality dashboard, I'll open that up in a different, let me just say, play with this. You can click on this and see some, comparative metrics, you against other practices, and lots of drilling down and so on, usual kind of thing. Wherever you look at a metric you want to go further, just hover over it. Usually you get more detail. And sorry, I've got a tab lying underneath the Zoom scroll down. So this is the primary care quality dashboard. This is looked at a lot. I think this is a little bit too much prominence. It's what happens when you kind of produce a scheme that potentially is looking at the quality of practices. And really, we've got to look more at the KPIs because that tells us what we're really doing. Some of the KPIs appear here, not many, but it is good, especially on this clinical outcomes. So I would check your quality overview, then go to the clinical outcomes. Most of you have got the things like the other areas sorted, although you can quickly see from the quality overview where there are issues. So let's go to sex across. Well, we're okay at the moment overall, but I think if I saw on clinical outcomes, we weren't that special on, here we are. So we've got a couple of reds here. This one, if you hover over the thing, by the way, it will tell you some more detail. So this is our uptake, and we're less than the target of 80% for cervical screening, and our rate for under 2 vaccinations is not great. So we've got to look at those. They've traditionally been areas where we've had to work really hard to get our numbers up. You can drill through, so if I want to look at that cervical screening, I can drill through, and I'll be taken through now to the dashboards where I'll be able to compare myself. And this, remember, we started off early on looking at the dashboards. We had admissions selected. This time it's clinical, and we're looking at something that is an overview, but it contains the screening, and it has, I've chose screening, cervical screening. There are our figures, 10 out of 13. Remember, that's where we expect to be. Still, we're at 78. We've got to push ourselves above that 80% marker. Right, we have 3 minutes to go. I knew this would be tight because there's a lot to be discussed from your list. I hope we've covered a lot of what you needed to cover. I'm sure we'll have skipped over some areas, but I'm very happy if you guys were to email me afterwards with things that weren't clear. But we've got 2 or 3 minutes for questions. Any questions that people wanted to raise? And let's say this time we can make on anything we've received, but clearly on primary care quality dashboard, for example, if it's specific to that.
Anyone?
No questions?
No?
Is it that clear? Or is it that bamboozling? Actually, what would be useful to do if you could collect some feedback afterwards. This is the first time I've ever tried to do one of these more interactive tutorials on Zoom, and clearly it's not the same as talking to a live audience, where it's easier, isn't it, to get talking to a bunch of people. The second thing to do is to go on the home page to the help, which is, there are various ways of getting to it, but you'll see the help document here on the help page. And incidentally, current NUH admissions, and dare I say it, Sherwood Forest admissions, I'm pretty sure they're on that list. I don't know where it says NUH. And Douglas and Bassett Law are certainly there too. But yeah, that help document is a 55-page document, which we will update shortly.
Okay.
If you need further help, you can always dump it onto the user forum. To get to the user forum, it's under social and forums, and you'll see so if you look at the user forums of most organizations, you will see perhaps 10 messages. So you'll see that we've got certainly hundreds, and when it comes to the general discussion, which includes all the stuff around issues log, for example, thousands of people responding. So anything there, like, you know, information request, whatever, dump it there, and we'll respond to that. And the team are really good at responding.